Here's a biopsy from a transplanted liver. This woman did not adhere to her medication, and hence this result. When you look at this biopsy under relatively low power, you notice there's a lot of blue. These are portal tracts, and virtually every portal tract has a substantial amount of inflammation. The lobules seem relatively undamaged. Let's take a look at this portal tract, and this particular portal tract shows what I would consider the most dramatic example of endotheliitis. So what is endotheliitis? Endotheliitis, one of the defining features of acute cellular rejection, is characterized histologically by these sneaky lymphocytes that are undermining or go beneath the endothelium. So here are the endothelial cells. They are damaged and they're lifting off, and these lymphocytes are coming in beneath the endothelium. This is endotheliitis. The second feature that defines acute cellular rejection is a mixed inflammatory infiltrate. What do I mean by a mixed inflammatory infiltrate? So it's a portal infiltrate that is composed of obviously small mature lymphocytes, but also larger, more activated lymphocytes, as well as these eosinophils. So these activated lymphocytes and eosinophils define a mixed portal infiltrate. And in fact, if you look at this biopsy, the majority of portal tracts are infiltrated by this mixed inflammatory infiltrate. This particular portal tract also illustrates the third classic feature of acute cellular rejection, and that is bile duct injury. In fact, this particular bile duct is so badly injured that defining the presence of a bile duct becomes a challenge. There is the bile duct right there. Notice that there is intraepithelial lymphocytes that have entered the bile duct. Here's the accompanying arteriole. Here's another markedly expanded portal tract, again with that mixed inflammatory infiltrate. There's the accompanying arteriole, and here's the damaged bile duct. There's loss of some of these ductal cells. There is clearly loss of a ductal cell here, eosinophilia of the ductal cell, some variation in nuclear size, all of which are features of bile duct injury. This is, of course, fairly classic for acute cellular rejection. It's a very severe form of rejection. What was somewhat unusual here is the fact that there was interface hepatitis with necrotic hepatocytes, as well as a rather marked panlobular hepatitis. Notice these lobular inflammatory cells along with these dead hepatocytes. There was no other evidence of a second infection. EBV stains were negative, CMV stains were negative, and an immunohistochemical stain for C4D for acute humoral rejection was also negative. Bottom line, severe acute cellular rejection.